Hello, and welcome to this Cardus webinar, Is Canadian Healthcare at Risk? My name is Ray Pennings. I'm the Executive Vice President and co-founder of Cardus, and I'll be your host this afternoon. At first glance, the answer seems obvious. There's stories in the news of overcrowded emergency rooms, overflowing ICUs, a shortage of family doctors, and a waiting list for surgeries. These days, we're hearing radio ads in which both levels of government are trying to scapegoat the other for the $28 billion shortfall they say is in healthcare. Canada ranks second in OECD among per capita health spending of 28 countries. However, on most outcome measures, we're somewhere between 14th and 27th. Cardus is a think tank focused on imagining a thriving society. And the answer to these questions, required if our fellow citizens are going to flourish, don't just require thinking about what the politicians and the bureaucrats, what the lawyers and the judges are going to do about this. It also requires thinking about these challenges and finding solutions that work at a very personal level for ourselves and for our families. What does it mean to age and to die well? We recognize the reality of vulnerability, mortality, and suffering. Are these matters simply ones to be best avoided and not talked about? Or is there a way to prepare for them, to give meaning to suffering, and to build on our relationships to help us through these times? And what does that mean for palliative care, for long-term care, for home care, for hospice care, all the places where healthcare might be delivered? Is the current way the only way? Is it the best way? Or might some of the presumptions about our present system be part of the problem? And are these only issues to deal with at the end of life? Do the current challenges of social isolation, well documented for some time but brought into focus by the recent pandemic, does that have healthcare implications? Can we really just concern ourselves with biology and caring for our bodies and our physical needs without paying attention to life's mental, spiritual, and social dimensions as part of the care plan? Might how we live with who's in our family and in our social networks, who will take care of us when we're in need and who we take care of when they're in need, might that have some impacts on our healthcare system? And then there's MAID. Since 2015 Supreme Court decision on this matter, the issue has been on the national agenda. Technically speaking, MAID is more an issue of law and constitutional rights than it is of medicine. Historic definitions of medicine have involved the Hippocratic Oath and have focused on the life of the patient. Whatever your views might be on the legal rights that ought to attend as it relates to assisted suicide, to call it medicine is to change the historic meaning of that term. And while the political and the legal process sort themselves out, we have a parliamentary committee that will report in February, and the law is going to change again in March of 2023. The reality continues that even today, the medical system has experienced significant change as a result of adapting to MAID. And the implications are real. Not just for the patients seeking counsel with their own doctors discussing the end of their own life, but for all of us, as it relates to the allocation of resources, the creation of conscience conflicts for healthcare workers, and the ethos and ethical decision-making of all that shapes medical care. Cardus has engaged with these issues since 2015. We've hosted various events to facilitate conversations. We've conducted case studies in both of the cities where our offices are located, Hamilton and Ottawa, Ontario. We have worked in concert with the International Compassionate Cities program to help establish Compassionate Ottawa. And in 2020, we undertook some national survey research on this topic in partnership with the Angus Reid Institute. When Canadians are asked about MAID in general terms, 1 in 3 is very supportive. 1 in 5 is totally opposed, and almost half are somewhere in between. Supportive that MAID is available, but concerned for the vulnerable and negative implications that come from its use. And when you ask the question more specifically, 2/3 are concerned that what is being presented as a personal decision between a patient and their doctor may end up being not such a personal decision in reality. They share the concern increasingly reported in the media these days that the elderly and the disabled are seeking pressure to face MAID, having their condition determined explicitly or implicitly to make them a burden on their family and the public. They also recognize that the simple availability of assisted suicide would place the pressure on our healthcare system, a system already not able to provide the care required. When the required care and social services are not being provided as a meaningful alternative, can we really say that the reality of choice exists? Cardus has attempted to deal with these and related questions over the last few years as part of our general public commentary. Recent events have made it increasingly clear, however, that we needed increased resources to do justice to the theme. And so it's my pleasure today to announce the fact that in recent months, we have been successful in raising the required funds to get us going. While there's still a long ways to go, we are able today to relaunch our Cardus Health program. Our first act is to issue a job posting. We are looking to hire a full-time director for Cardus Health, someone who will be able to coordinate a research agenda, build the networks, and link our work with the many good individuals and organizations who are doing good work, as well as many frontline institutions who have questions and would welcome our research in finding the answers. Part of the task of the Cardus Health Director will be be the public face and spokesperson for this program, engaging in public dialogue, sharing the research, and getting the relevant data into the national conversation so as to help address these challenges. We understand that this won't be easy and will require an in-depth understanding of the present situation, which leads me to a second announcement. We are not undertaking this alone. We've been delighted to secure the agreement of 3 leading healthcare professionals to serve as Cardus Senior Fellows and together as the advisory committee for this new program. And those individuals just happen to be the panelists that we've invited to join our discussion this afternoon. You can see their more complete biographies and impressive list of credentials on our website. In the interest of time, let me just introduce them, and then we can hear from them rather than talking about them. First of all, we have Dr. Leonie Herx, a palliative medicine consultant and medical director, comes from Kingston. We have Dr. Peter Tanis-Patru, a family physician and a healthcare researcher based in Ottawa. And finally, we have Dr. Eric Wazilenko, a clinical ethicist and a recently retired palliative care physician from Calgary. Thank you to the 3 of you for being willing to lend your time and expertise to help Cardus build this program. We're thrilled to have such a distinguished team, and we're excited about what can be accomplished. There's much more to be done, so let's begin by talking about it. Let me start with Dr. Herx. Leonie, your resume shows a career studying, practicing, and teaching palliative care, and you've been credited by many with growing this discipline. You're the past president of the Canadian Society for Palliative Care Physicians. Maybe you could start by introducing yourself a bit. Tell us why you chose palliative care and what concerns you most about where the discipline is heading today.
Thanks so much, Ray. It's a real honor and privilege to be part of the Cardus Health team and to share with you a little bit about our work today and what we're envisioning for the future, as Ray said, to help people live well and thrive. So that's exactly why I chose palliative medicine. It's really about helping people flourish and live their best lives until the end of their life, and helping people die well naturally, which most people do. And those that have more complex symptoms can be supported by a team member like me to make sure that they're comfortable during the dying process. So really, palliative care is about helping people live fully and maintain their dignity while facing the challenges of serious illness and life-threatening illness. And to do that, we address the whole person, the physical, the spiritual, the social, and the psychological aspects of what makes us human, because it's all of those mixed together that through that we experience our suffering. So to address suffering, we have to address the person in his or her entirety and in the context of his or her caregivers and family. It's been a real struggle in palliative care to improve access to care. We have a patchwork of coverage across the country, depending on your postal code, your diagnosis, your age. And to really achieve palliative care as a human right and be universally accessible has not happened in Canada, and really is a standard that should have happened before legalization of assisted suicide and euthanasia. But here we are. We really also have been impacted by the use of euphemistic language and the conflation and ongoing confusion of palliative care and MAID. So providing education on the differences between palliative care and MAID is hugely important, and has contributed to the misunderstanding of what palliative care is. So we have a long way to go in terms of education and helping people live well with dignity, but I know we can do that together. Thanks, Ray.
Great. Well, thank you very much, Leonie, and we're excited to have you. Dr. Tennis Panetru, sorry, I knew I practiced it before the, can I call you Peter?
Yeah, of course, Ray.
Peter, in addition to your own medical practice, you're a researcher and you use big data to look at policies and care at the aging at the end of life. In our conversations, you've mentioned the inequality of palliative care's availability and the random lottery, I think you called it, embedded in the system. Leonie touched on that. Do you want to expand on that a bit about the inequality that exists in the system today?
Yeah, absolutely. And thank you for having me. And it's absolutely true. We have no systematic way of delivering enough life care right now. And I'm a family doctor and provide home visits for my patients when they're dying. But I always ask people, do you actually know if your family doctor will visit you if you're dying? And I think most of us recognize that we want to provide care in places where people feel most comfortable, and that place usually is home, right? And when you ask someone, does your family doctor provide that care in the home setting, most people do not know. And in Canada, there's no standard in providing that care, so a lot of people do not get care in their place of setting, in their home, and instead have to resort to the hospital. And that just kind of speaks to the non-systematic way that we deliver end-of-life care. And that's a problem, right? We don't think of a good death as a good part of life lived, and it should be, right? It can be a very meaningful experience. And people talk about palliative care as being very difficult, especially to go into, but it's not. It's one of the most rewarding, one of the most enlightening, you get a lot of satisfaction providing it, because there's a lot of meaning that can be provided in the dying process. But unfortunately, we don't deliver that care. Only 1 in 5 Ontarians, for example, before they die, will get palliative care in the home before they die in their last year of life. Only 1 in 5. So what happens to the 4 in 5, right? What happens to the 4 in 5 that do not get that care in their home? Well, it's completely a random lottery right now. Who is that 1 in 5? And we need to change that. And there are ways that we can change that, and there are other countries, other jurisdictions have figured out ways to do that. But Ray, we still need to work on that in this country.
Thank you, Peter. Dr. Wazelenko, Peter talked about the satisfaction that comes from being a family doctor and providing that care. You just retired from a career in that I know included a good amount of visiting patients in their homes, and you've spoken about the importance of home care and hospice care as part of an effective healthcare system. Tied to that is understanding. It's not just where the care is delivered, it's also about understanding your patients and the values that they have that you need in order to do a proper diagnosis. When we chatted the other day, we talked about a little bit in terms of understanding the cases that were there and how things have changed over the course of your career. Do you want to just reflect a bit on the change that is happening and the trajectory that we're on in our healthcare system?
Sure. Thanks, Ray. And thanks again for the invitation. It's a real pleasure to be part of this team. So I'm going to take a little bit different focus and talk about what I see as kind of a 7 big shifts that I've seen over the course of my career. You're taking me back to 1979, 1982 now. So some people on the call wouldn't have even been born yet. We listen to patients more now. and we try to understand their goals in a different way. We recognize that medicine really is a mere intervener in how people's lives might unfold. And so I get the sense we would probably guide more now rather than tell. And physicians' roles as gatekeepers are changing. There's a risk, though, that some people will relegate our role to being technicians there to do people's bidding and to meet that particular demand. And that changes the nature of the patienthood that people bring to us and its inherent vulnerability, and also the nature of the physicianhood that we bring to the relationship as well. Secondly, we work now in teams, and that includes the patient and the family, and that's just really central. It's obvious to everybody who's working now, but that wasn't the case 40 years ago. And that makes a big difference in this conversation. Thirdly, we use knowledge better, and it's been democratized in a really important way, sometimes for good and sometimes for bad. But that information is in the hands of many of our patients and families. We also use health data in a much more dramatically powerful way than we ever did before. Interestingly, this brings me to the fourth point. We recognize that the recommendations that we provide based on research usually involved white male subjects. And that may not apply to women and to people who are not white. And we've realized that only in the last number of years. And so this drives us to personalize our approach in different ways, to research differently, and to speak to different people differently regarding their cultural and religious and emotional and family contexts that are very different, their socioeconomic status, etc. The fifth point is that the population is aging. We all know that, and some are living very healthy lives in their elder years. Some have marked frailty and major dependency. When I started medicine, elderly was 65. Well, that's not the case any longer. It's become harder to die over these years as well. So we can apply now astounding technology that saves physiology and keeps people alive. But the difference now, I think, is that we recognize we've got to think about what is this whole person and how do we think about their whole being, whether it's their spiritual or emotional, their relationship being as well. An example is that cancer for many people is now a chronic disease. It isn't for everyone, though. And that raises the conversation for us about the meaning of life and of suffering and of goals of care, the goals that people bring to how they want to live, the purposes of our interventions. Just because we can do something, ought we do something, is a question we often ask. What about the burden of those interventions on people and on their families as well? And then finally, the last thing to mention is that more people are alone. We have smaller families. The birth rate has continued to go down over those intervening 40 years. People are more distantly placed where they live. There are more single elderly people. And that raises the idea about healthcare as one piece of the social or relational puzzle of our lives. So instead of us running people's lives as the healthcare system, especially from acute care, we're now saying people invite us into their homes to help care for them as one part of their team that's helping them live, and as Leonie said earlier, to flourish as well as possible. Thanks, Ray.
Thank you. That's excellent, Eric. Those seven points. Leonie, let me just pick up on what Eric was saying in terms of understanding the whole patient, the democratization of that, and understanding their various dimensions. When we gathered as a working group this summer to sort of paint where we might go with this program, we identified 4 themes. And the first was talking about vulnerability and mortality as natural and meaningful aspects of human life. And one of the words that was used in that was dignity. And I'm wondering whether or not, there's another organization that has dignity in its name, which has been very involved in the healthcare debate, which understands something quite different than that. Can you talk a little bit about the dignity that is provided in terms of palliative care and in terms of this approach to care, and contrast that with the understanding of the term as it's commonly being used today?
Absolutely. Yeah, it's so important and foundational, of course, to good care, especially good palliative care, is that our dignity as persons is just inherent to the fact that we're human beings and not what we can or cannot do. And we know that changes in function are part of aging, and they're also part of dying. And there seems to be this societal I would say, misunderstanding or cultural view that because you're less able to do something, you're a burden to other people. And without that kind of community network that we're talking about, that so many people don't have in today's society, there's this sense placed upon them, I think, externally and maybe internally, because of our cultural views, that we have less dignity. And so one of the things that palliative care has worked so hard on, and one of my colleagues, Dr. Harvey Chachanoff, has spent his lifetime researching and studying this, is how do we not only conserve dignity, but enhance dignity in the care that we provide? And it is those things that Eric was just talking about, like what matters to that person, who are they in the story of their lives, and what is important to them, what are their wishes, like, so that has to be the very foundation of all the care that we provide in order to really enhance that dignity. And we have therapeutic interventions in palliative care that enhance that. And even a simple question that every healthcare professional could ask is, like, what do I need to know about you to best care for you? Like, we have small tools like that that are like just game changers to enhancing a person's dignity and understanding them as a person, as the center of the care we provide.
Eric, as you have asked these sorts of questions along the way, one of the terms that often will come up, and I'm sure you've encountered that, is suffering, which is seen as sort of an antidote to dignity. How do we, are suffering and dignity in conflict? Those on the other side of the MAID discussion, or those promoting MAID, have been saying, well, the real answer is to avoid suffering. How do you square these two together, dignity and suffering?
It's a really good question, Ray. And, I am not one who says that I want people to suffer. Our purpose in medicine is to help decrease suffering, not stop it necessarily, but decrease it to a tolerable level. So, because suffering is toxic to the human condition, basically, but it's also the purpose to try to help people flourish as much as they can, to live the life that they can as well as they can. And that's why we try to provide interventions and help in caring for people at the end of their lives through palliative care, and at any time, so that they can thrive and flourish individually, and that helps society to flourish as well, of course. So they aren't mutually exclusive. Suffering is part of the human condition, and the avoidance of suffering is something that we usually want to do, but maybe not at the expense of basically being alive or life by itself. So there's this notion of personal suffering and community or family suffering and those around me. We all really want to help others that are around us avoid suffering also. But it brings back to some things that Leonie was saying, and it made me think about the relationness of our lives. And so we each have really beautiful, I think, heartwarming stories about how a person's family, they might be professional caregivers, they might be friends, they might be kids of a dying person, help to create the structure of loving care surrounding the person. That's what the hospice movement is about. It's what palliative care movement is about, but it's about what individual families do. So it's only a couple of generations ago that we were born at home and died at home. And it was just part of the fabric of our existence. People weren't afraid of the conversations of death. People didn't want to die or have their loved ones die, but it was part of the understanding, the arc of human existence that people acquiesced to, that they would die. And so the ability to help somebody through their symptoms, their suffering, their loneliness, the emotional and spiritual impacts of potential present death is a very human experience that helps the person grow and helps their loved ones, their family, grow in very, very unique ways. So I've always said, look, the time of the approach of death isn't a time of waiting and suffering entirely. It's a time of growth. It's a really important part in the arc of your life for that growth. And so the dignity that surrounds the relationness of our being with others and the ability to receive love and to give love is fundamental to how we are as human beings.
Peter, let's segue off of that to the second theme that we talked about as a group, aging and dying well. You're involved in looking at a lot of macro data, big data. I think both Peter and Leonie have talked about the evolution of care. We've democratized care. We've brought it home. We've brought others into the picture. As you think, the numbers in terms of the numbers of baby boomers that are coming through the system and the amount of dollars we spend at the end of our life, when you look at the data and you look at healthcare sustainability in the long run, what are some of the changing roles that we can expect for the various institutions in society? We've got the healthcare system, we've got the individual and their families, their extended families, perhaps their religious or their home communities in terms of care. Can you talk a little bit about that evolving nature of care, sustainability, and the different institutions that will be involved?
Yeah, no, that's a great question, Ray. And I think we all recognize that dying, it's part of medicine, but it's much more than that, huh? Like it's, the kind of care that we deliver at the end of life, I find it's often not medicine, right? It's not giving drugs. It's not, treating symptoms. It's often alleviating fears, talking about what that dying process looks like, and answering questions about, what it is to die. And a whole big part of that is what others have talked about is not, the medicine part of dying that needs to be there, but everything else, right? Your family, your loved ones, people to care for you. And, we go in there when we can provide medicine to alleviate suffering. And that's one of the misconceptions out there, that people have, this perception that dying is always associated with suffering, right? I will suffer when I die. But, when it comes to physical symptoms, we have a lot of great tools to provide, people so they don't suffer physically. But in order for that to happen, we need to deliver that care, and we need to deliver that care in a timely way, and have access to physicians like Leonie and Eric and myself, in a timely way. And that's just not happening. And it takes a whole system effort, I think, to kind of put that in place. And what's really staggering, I mean, we hear about, you mentioned it earlier, Ray, that, the hospitals are full, right? ER is full. There's lots of beds that are full. Bill 7, the controversial Bill 7, it tries to push people out of hospital. But, how about preventing people from going to hospital in the first place, right? No one wants to be there. And end of life care is a win-win, I find, because no one wants to be in acute care hospitals. And there's this misconception that you have to be in hospital to be provided good care at the end of life. It doesn't have to be that way. I think we're proactive and provide that care in places where people want to be, at home, and in those natural settings, whether that's your private home, retirement home, long-term care home, hospice, right? I think those are the places where we should be providing care. But our research has shown that's not happening, right? Over 50% of the cost at the end of life is actually borne in acute care hospitals, right? And we're talking about acute care hospitals in emergency rooms, not complex continuing care and these subacute care facilities. It's those beds that we're trying to free up. And to me, it's a no-brainer. We need to have a whole system approach so that we can divert people away from acute care centers where no one wants to be. It's a win-win. You save costs and people want, receive good care in where they want to receive that care.
Leonie, you spent part of your life teaching as well as practicing. As you are preparing our doctors for tomorrow along the way, is the curriculum you're providing and the expectation they have of a very different mix of hospital, community, home care? And let me just name, we talked about hospitals. I don't think we'd be complete here without bringing to light something that most of us discovered during the pandemic, and namely our long-term care facilities and some of the conditions of them and the challenges that were there. I think many, obviously a disproportionate number of COVID deaths happened in that context, and there were real concerns about that aspect of the system. As you, from your perch as both a practitioner and an instructor of the next generation of doctors, how do you see the mix of the different facilities that are there and the strengths, weaknesses, opportunities? Take it where you will. I realize I just invited you to fill the rest of our time, but maybe condense it to just a couple of the high points.
Sure. I think first and foremost, we do not have good education about palliative care embedded into all of the health professional training programs in the country. And I'm not talking about just medicine, nursing, social work. PSWs, like everybody needs to have basic competencies in providing a whole person approach to care and palliative care, and needs to understand what normal dying and death look like, because it's been so misrepresented by the media and amplified through advocacy campaigns, I think, with the legalization of MAID, to make dying and death sound like this terrible, horrible suffering process. And as we've said here today, it's most often not, and good palliative care can alleviate your symptoms. Like, I've, in 15 years of practicing palliative medicine, I haven't had a patient that I haven't been able to help be comfortable at the end of life. Not that there aren't difficult cases, but we have a lot of tools and interventions that we sometimes now don't have the opportunity to provide because of the way MAID is being administered. But I think that we need to do also a lot better way of integrating these systems of social care that we're talking about, our faith communities, our friends and family networks, and all of those things that help us live well, into the institutional setting. There's been this real separation, which again was like more amplified through COVID-19, where we couldn't have visitors, and those supports that help us face, when we're feeling despair and facing a life-threatening crisis. Like, we need our social networks and the things that give us strength, and not be cut off and isolated in our long-term care centers and our hospitals. And a lot of the requests for euthanasia have been because of social isolation. In fact, there is a prominent case in the media of a 90-something-year-old woman who requested MAID because she didn't want to go through another COVID lockdown at her long-term care. Like, just speaks to the importance of having our social supports and networks and our communities integrated into our healthcare. And I think hospitals and long-term care need to do a better job of that. And I think we have strategies that we can help with that. So look forward to being able to work on some of those pieces.
Eric, among the titles that you have is ethicist, and a lot of these issues for individual healthcare workers are posing real challenges in terms of what they think they signed up for, and how they're being asked to do their job. Do you want to just reflect a little bit in terms of the link between individual conscience and health ethics, and where some of the boundaries are, when it is that, as part of the obligation, as you outlined, in terms of understanding what your patient's desires are, but also the boundaries that you as a medical professional upholding the Hippocratic Oath want to carry out? Can you just reflect a little bit on that relationship?
Sure, Ray. It's a really difficult area to talk about briefly. I'll try. So healthcare is a human endeavor, and what we bring as healthcare providers to the equation of that interaction is really important. And we need to bring the best of ourselves, and that includes our moral selves. We make very, very tough decisions with people and for people, and we have to be able to tap every resource we have, including our moral foundations, including our conscience. So while it is true that we are here to serve others, and we need to listen carefully to what they express their needs to be, we have to also bring our own sense of what's right and wrong to that equation, so that we can adequately and appropriately guide the people that we're meant to serve. And that becomes really challenging in this environment where we might be told, here are the things you must do to provide particular kinds of care. It's challenging both for individuals, and we see many examples of people feeling really morally distressed. It's an interesting thing that's playing out right now in the liberalization of the assisted death regime in Canada, where we've heard anecdotal stories and a little bit of literature work now, that many people who were providers of assisted death are saying, well, we might have gone a bridge too far now, and we're not interested or willing to provide assisted death for those people who say aren't dying anyway. That might be the language that's used. And so the ability to be able to say, here are some things that I will or won't do, I think is time honored, and it is part of our relationship with people. It is, as I said earlier, what we bring to the equation. It's something that we're really losing currently, when we're being told you must do X and Y regardless of your moral stance. It is, I think, a real challenge, and in fact, it hurts all of our patients, not just this individual patient we might be talking about who's choosing assisted death or not.
Peter, picking up on that, I understand the data is relatively limited in terms of the self-selection in and out of the healthcare system on the part of workers, that, you know, and allocating it to specific reasons. But, you know, do you want to maybe describe a little bit of the overall healthcare, you know, shortage that exists and some of the challenges that this is introducing into that equation?
Yeah, no, absolutely. I think there's a whole crunch, right, on the healthcare system, not just doctors, but nurses and PSWs. And we're having a hard time, you know, providing care, you know, adequate care for patients. And I think it's, I mean, we've, you know, done, we've talked about the issues with MAID. You know, I feel that one of the biggest challenges, you know, in cases of MAID is, you know, I feel that a lot of times we're not providing optimal care for them, you know, prior to that decision to choose MAID. And part of that, is it the healthcare system's inability to provide care? Well, I think we have to organize ourselves better. You know, I think it's a travesty that, you know, not everyone is getting that optimal care that they should be. You know, and by the time they reach that decision to choose MAID, you know, they have been suffering, right? And should, you know, and you know, providing care at that time is already too late, right? I think Leonie and I had this discussion, you know, where we have many cases of people who've, you know, made that decision, and they've made that decision because of the suffering that they've had. And part of that suffering is physical suffering, is fear about what's going to happen to them when they're dying. You know, it's the whole shebang, right? And you know, in medicine, you know, we have excellent tools to provide to individuals, not just symptom relief, but to help them and guide them through that dying process. But we're not doing that for the majority, I would say, of the population. And we need to change that. And we have to mobilize our healthcare system in a way that allows us to do that. And, you know, Ray, myself and Eric, we're family physicians. I think part of the solution is really enabling family physicians to go out and provide that care, you know, for everyone. And, you know, we have this saying that path care is everyone's business, right? And it needs to be everyone's business for us to reach everyone. It can't be just the Leonie's path care specialist. You know, all her patients are lucky to have her, but you know, we don't have, you know, 100,000 Leonies out there. You know, it needs to be a team effort across all disciplines, across all specialties. And I think that's where the trick is, not in, you know, path care specialists only. They're the experts, but it's, you know, enabling everyone, involving everyone to deliver that care.
Can I jump in?
Please.
Just to add to what Peter's saying, absolutely. But our communities and all of our, like, as you talked about compassionate Ottawa earlier, Ray, and I think that the community grassroots level, or whatever community it is, your church community, your card playing community, we can be there for each other. And I think that we need to really work on that as a priority.
Yeah,
excellent. That segues perfectly. The fourth theme we covered was loneliness and social isolation. And one of the things when we met for a couple of days in August with the Cardus team, as well as our three senior fellows on this. And one of the things we wanted to highlight, that while MAID may be the immediate change in the healthcare system that a lot of eyes are focused on, there are many more dimensions to this change that need to be captured in terms of Cardus Health. This is not simply a program about one particular ethical and controversial issue. It is about a sustainable healthcare system that's necessary for a thriving society. And the challenges of loneliness and social isolation were there long before we started talking about assisted suicide in the intense way we have over the last few years. Eric, let me just invite you. I know that part of your background was as a family doctor in rural Alberta, and part of your history is being among the early organizers of a local hospice and organizing the community to be involved, and not just looking at a top-down centralized system, but creating some bottoms-up movement. Do you want to briefly tell us a little bit about that experience?
Thanks, Ray. Well, yeah, recognizing that many more people, especially in rural Canada, need to have access to integrated palliative care programs. We've always said that to have a really good community-based coverage for palliative care. You need palliative care expertise and programs in hospitals, in acute care, in hospices, in people's homes, and in long-term care. So trying to create that umbrella for people is really important. And interestingly, we were successful in fundraising and developing as a community from community volunteers a really fantastic location or facility for people in rural Alberta, near where I live, near Okotoks, just south of Calgary. And it's still a going concern. It's been in operation for 14 years now, I think. It's been open, and we're now really moving aggressively into saying we need to expand, for one thing, physical space, but we also want to make sure that that becomes the outreach place for people in the community to be cared for. So can we provide better residential respite? If people want to stay at home, but their family needs a bit of a break, or their patient needs to come in for some symptom management tune-up, can they come into the hospice for a number of days or a week and then head back home again? If there is some community programming, so people can come in and get some Reiki therapy or some physiotherapy or some symptom management or some social contact during the days at a facility like a hospice, can you do that? And can you have community members centralized as the, sort of formal volunteers, be committed to making sure that people can be driven in the community, that there might be a break for a family member, a spouse, to go out and have some of their own social interactions, or get groceries, or do those kinds of things, so that as a community, we're kind of caring for each other in this really important way. And part of the genesis of that is to say, look, it shouldn't be the formal health system or the government who provides this encompassing care for each other in our community. It's our job as community members. It might be our job as a service club, or it might be our duty as a religious community, or many other organizations that can say, look, we just need to step up and help people live well in community. That's really the genesis of all this, and there's many, many different ways to do it. We've been really fortunate to have some pretty strong success, and we recognize where the gaps are, and we're trying to fill them now as well.
Great. Well, time is moving quickly, and we want to honor the promise that we had to all of our watchers that we will conclude this webinar within the hour. So let me transition. We've just touched the surface of the range of questions at both a research and a policy level that we expect the Cardus Health program, under the leadership of the program director that we hope to hire very quickly, and under the direction of this team to undertake. Before we conclude, let's just very briefly, I just got one final question for each of you regarding the various contact points of the healthcare system that the ordinary public is likely to encounter. And Dr. Herx, you work in a hospital setting primarily. Can you make a few comments regarding the challenges of those health institutions, the role they play? We asked the question at the very beginning. I realize you touched on this a little earlier, but let me ask it in medical terms. If the title of this webinar was, "Is our healthcare system at risk and sick?" Which are the sickest parts, and do you have any prescriptions that you're prepared to diagnosis and prescriptions from palliative care? Hopefully, when it comes to healthcare, not the palliative care.
Well, I mean, I think we're in a health human resource crisis across the healthcare system. Acute care is particularly impacted, and I do work in an acute care setting. But I think in part it's impacted because we are not investing in our communities. People want to be in the communities for their care, but we're not investing and putting in the integrated care programs that Eric referenced earlier in our communities. And I see that in palliative care. We need to make sure that we have physicians and nurses who can go into the home and have a process for direct admissions when those people need help without having to go through the emergency room, for example. And those systems exist, and we have good models to look forward. But I would say community-based care has been most stripped through the COVID-19 pandemic due to staffing shortages. And we have more and more people coming to acute care because it's the only way they can access a health service or see any type of clinician. So I think we really need to reprioritize funding and putting resources into the community-based care settings, including subacute hospitals, community hospitals, and home care and hospices. Definitely a priority.
Right. Eric, when we were chatting last week, we talked a little bit about the nature of innovation, and obviously Cardus Health is about doing some research and recommending changes. I was struck by you sharing a story with me of the concern that you have of doctors no longer being forced to sit by the bedside of a patient because of alternatives having been sought. And you talked to me a little bit about the innovation that came from challenging situations of care when you felt the need of the patient in front of you and didn't have a ready answer, and were consequently creative in terms of how you thought about your task. Do you want to just pick up on the theme, necessity, and ways that innovation enters healthcare?
Sure. Thanks, Ray. And part of that story was around my notion that it will be easier for us as human beings looking for a solution to a problem, potentially, to take that easy way out when you're forced not to take the easy way out as clinicians, and look for one more innovative way to help, say, a patient with their symptom management middle of the night while you're sitting with a patient. You do get creative, and we learned to use all of our resources in a really important way, including community pharmacists, to develop and compound novel ways to deliver medications that a patient might have needed. And that comes from not having that way out. But, touching on something Leonie just said, and your view about innovation, Ray, there are good models out there. They do exist. We've shown it in small areas throughout the country. We need to have the opportunity to not have to recreate all those, but to learn from them and do them. We have had tremendous success in many of the areas that we've talked about today. So a few thoughts though. Number one, we need to make better use of data, and we're really focusing, certainly the University of Calgary has a connection to precision medicine as a really important jump for the next number of years. And precision medicine will help us, back to some earlier comments I made, to tailor make solutions to individual patients and their physiology, their history, their genetics, and their social construct. We need to do that better. We need, there's expectations that people want to be involved in their decision-making about their own lives and their care in a very much greater way today than ever before. We need to build on that opportunity to have partnerships with the people we're caring for. We need a realization and acknowledgement that our health system, as it's currently constructed, focused on hospitals, cannot hope to meet the population or individual health needs. And hospitals really should become very important, but bit players in the healthcare and social care landscape of a person's entire life. They're critically important bits of our health system, but the health system ought not to be focused on it. And finally, we need acknowledgement that healthcare is not separate from social care and our duties to each other to help people thrive. Those ways of thinking about the system differently, using precision medicine and better data to get us where we need to get as we have this huge wave of people needing our care, will make a difference. We have the tools, we need to mobilize them better.
Wonderful. And Peter, my final question for you, let me just say how thrilled we are that you're part of the team, because you bring a very unique mix in terms of your family practice of medicine, as well as spending a significant amount of time not only doing your own research, but also advising supervising PhDs and a number of others who are doing significant research in the healthcare system. You've probably got a very good feel of the bigger picture of the research trends and all the rest. I was thrilled when you said yes to the invitation to join our team. Maybe what are some of the questions that you're hoping Cardus Health can help us answer? And particularly, does the fact that Cardus is an institution that approaches this from 2,000 years of Christian social thought with a particular view of the human person, does that make any difference in this entire discussion?
Yeah, and it's an excellent fit, for Cardus to be in this space, right? I think we all recognize, when people are dying, a lot of that suffering is not physical. I think we've touched on that a few times, right? A lot of it is spiritual, is, people asking about the meaning of life, what's going to happen to me afterwards. And, it's, one of the hardest parts of alleviating suffering is, alleviating, people who are in existential distress, right? What was the meaning of my life, and what's the meaning of my death? And I think absolutely faith-based, institutions need to be part of that solution, right? To provide, answers to some of those questions. And I think it's an important part of the dying process. It's a crucial part of the dying process. I always ask, patients, how do you feel about it? Because I think it's an important part for a lot of people. And when they don't have that component, addressed, I think there's a lot of fear about uncertainty about the future. About the data, I think Eric touched on it, everyone touched on it. We have reams and reams of data out there in healthcare, right? And, Netflix will tell you what show you want to watch next, Amazon will tell you what you want to buy next. In healthcare, we don't do enough of that. We don't, we don't use it, and we don't liberalize the data in a way that can help access to care and improve access to care, identifying people who are dying, identifying those people who are receiving MAID who are not getting that optimal care prior to MAID, for example. And, just identifying pockets of where people are needing care. You mentioned long-term care, for example. There's lots of data in long-term care where we can say, yes, these long-term care homes need help, this long-term care home needs help, and we're not doing that, right? And again, like the clear, there's a, the platform is very clear. Hospitals are full. No one wants to be there when, they're dying. There's a clear connection there if we mobilize, the healthcare system, but society as well, to provide that care. And I think use data to identify who's not receiving that care, and it's very possible. Then we can actually alleviate suffering. And in what I do, I try to use data, essentially to alleviate suffering that's happening in the healthcare system and in the population. And we're still trying to figure out how we can do that. And I think we have a bright future in doing that. And I hope Cardus plays a part of that movement, right?
Well, thank you. And thank you to all three of you for sharing with us. To the audience, we invited you to this webinar with the title is Canadian Healthcare at Risk. Why did we do this webinar? Well, we were excited by the fact that we had raised enough money to hire a full-time researcher, and we could just put the ad on the internet. We thought it would be more effective to invite you in and to share a little bit of what we're doing, and through this discussion, give you a sense of the range of topics that we want to explore, because this is really something that affects all of us. And so I want to leave you with not just an impression of what Cardus is doing, but also what you can do in the midst of this to help us along. And the first thing I want you to do is to help us build awareness. There's awareness every day of the challenges of healthcare. We just listen to a newscast every half hour. You can read your newspapers. There are real challenges in our healthcare system, and we need a broader conversation. The issue of healthcare in Canada has been extremely politicized, in which the minute innovations are there, all of a sudden polarized positions emerge. We're hoping to create an awareness and a more nuanced discussion of the issues and look forward and put forward solutions that hopefully can see the better health of all of our, not only of ourselves and our families, but of our neighbors as well. The second reason we are doing this is to build networks. You signed up for this. We hope to send you information on Cardus Health. Undoubtedly, all of you know people who are interested in this subject, perhaps medical professionals. Your help in spreading the word of building a network. My guess is that the person who we are advertising to hire as the program director is likely known to someone who is watching this webinar here. But they don't know about this ad yet, but the way they're going to find out is you're going to forward it to them. So your help in spreading and building our networks, in spreading the word, providing the support. We've been blessed over the last few months with some very generous donors who have caught the vision and have helped us lay the seed money. But programs of this nature need hundreds of thousands of dollars a year to carry forward. Cardus is a registered charity. We, if you're able, we of course would welcome your support. But your support isn't just in terms of the finances and support directly for Cardus. I really hadn't thought a great deal about this. over the last couple of years, Leonie and myself have been working with some disability, some legal and some religious leaders, as well as the medical community in terms of the debates of Bill C-14 and Bill C-7. Leonie has been a very eloquent witness at the House of Commons committees. We've been working not only to create an awareness of the legal and political issues, but also the issues as it relates to families and the care at the front lines. I don't have any medical expertise, and one of the things that I've learned along the way is that when in terms of the ethics of healthcare, and I think you've captured that from all three of our guests here today, it's very much looking in terms of what the patient needs in terms of life. And what we need to live is not to breathe. As a matter of fact, when we pay too much attention to our breathing, it's probably a sign we're not all that healthy. No, what we need to live, and someone wrote the fact that when we receive a terminal diagnosis, there are really 5 things that someone needs to do. There's probably somebody they need to say, I love you. There's probably someone they need to say thank you to. There's probably someone they need to ask forgiveness of and reconcile their relationship. There are those they're responsible for who they have to make sure will be taken care of after they pass. And they need to assure those around them whom they love that they themselves will be taken care of after they pass. Obviously, spiritual, depending on where we come at it from a Christian perspective, and there's a very clear holistic spiritual dimension to all of this. But as I think of healthcare, I think of Cardus Health. I think not about a bunch of political issues, but I think about the everyday care that we have for each other. And I'm quite excited by the fact that we're able to make this announcement today, begin the road to hiring a program director. I look forward to your continued interest and involvement. I thank you all for your interest this afternoon in joining us. God bless and good night.